Today, our first speaker is Dr. Todd Seto. He's a proud JABSOM alum, and we are also very proud of him. He's a cardiologist who maintains an active research program evaluating innovative ways to improve the quality of cardiovascular care and decrease racial and ethnic disparities in health outcomes. Please welcome Todd.
It is great to be here. Mahalo, Dr. Hinshaw, to invite me. This is it's always special for me to come back to the medical school, and I was old days. I was up in Manoa side, with the kind of biomedical building. So it's just a beautiful place, beautiful venue, and it's very nice to be speaking to you. I'm lucky to be a cardiologist, and I'm lucky to be a physician. And so let me start with a quick note, because we all look at the younger kids who are running around school here, and then younger kids who are in college and even below, younger than that. And what I say to them is that it's really the best time to be a physician. I know there's a lot of pressures, and a lot of my peers and a lot of your peers who've practiced medicine and have a concept of what it is. It's changed, definitely. So what my father, what my grandfather knew as medicine is different. And it's just changed. So I hear a lot of the young kids, students, children who are saying, my grandpa, uncle, auntie, my mom says, don't go into medicine. But I feel it's like my personal job, my task is to talk to these young doctors, young children, and say, this is the best time. There's so much neat stuff going on in medicine. There's so much innovation. There's so much still to be learned. And the way we practice medicine is just different, because the times are different. So much more technology. I had a question earlier, Dr. Imasu, about all technology that we have now. The ways we practice with nurses and with pharmacists and with physical therapists is just different now. So it's a great time to be a physician and a great time to be a cardiologist. So I'll start with this picture. So this is the heart. The heart is about the size of your fist. So if you make a fist and kind of put it over your chest, that's how big it is. And it's an extraordinary organ. And so the heart has, I think of the heart as like a house. It has 2 rooms upstairs, 2 rooms downstairs. And in this picture here, you have the 2 rooms downstairs, right? As the left and right ventricle, and it's cut away so you can kind of peek inside it. And the 2 upstairs rooms, we don't see that. I'll show you some pictures of that later on. And the heart really is like a house. 2 rooms upstairs, 2 rooms downstairs. They kind of work or pump in conjunction. There's electrical wiring that feeds, that's kind of buried within the walls, and we'll talk about problems with that. And there's plumbing kind of within the walls that bring blood to the heart itself, and the problems with that. So for me, the reason why I like cardiology when I was a much younger doctor was that this made sense. You can go molecular, you can talk about cells and fancy genes and things. I don't really understand that as well as I should, to be honest. I'm kind of like a big picture. I can put my head around what it is, and so I can see the heart pumping, and I'll show you some pictures and how that relates to disease. And I can, if I want to get a little bit more technical, I can look at blood pressures and things inside of the heart. The heart's just a pump, so the bottom part is just a fancy picture of the blood pressure, like taking the pressure inside of a basketball or a tire. You can measure pressure changes in the heart over time. So it's just really, I just want to explain that my love for cardiology is very tactile in a way, kind of very visual. And I think if you can do that, you can survive as a cardiologist. So far, so good, and do fine. Let you know that changes. So I thought I'd go through just the common conditions and focus a little bit more on the fancy, fun stuff we're doing now and what's changed. I know there are some friends of mine who are in here who kind of know a lot about this and also are very excited about some of these changes. And so when people say that I have heart disease, or when I see family that says I have heart disease, I always wonder, what kind? What does that mean? Yeah, because there's so many different parts of the heart, right? There's the plumbing, electricals, there's the pump, there's a sac around the heart. There's so much to the heart. What is heart disease? And I thought I would just touch on 1, 2, 3, 4, 5 parts of it. Yeah, so there's heart attack. That's one kind of heart disease, right? There's atrial fibrillation, or AFib. We'll talk about that in a second. That's an electrical problem. Kind of electrical system kind of goes haywire. There's heart failure, which sounds kind of judgmental, but it's really descriptive, kind of how the heart works. Or CHF, as kind of colloquially it's called. There's valve problems. So the valves are like doors between the rooms upstairs, downstairs. And there's aortic stenosis, or AS. Mitral regurgitation, or MR. There's a whole other vast range of heart disease. And I put this here partly to kind of give you a sense of what I'm going to talk about briefly in the next 15 minutes or so, but also just to kind of give you a sense that heart disease is really a broad term, and it could be many things. And some things are very severe, some things are not. And we often lump that together. So you see heart disease, sometimes it's a little bit vague as to what that means. So I start with the first one, and there's been some changes, I'd say, within the past few years that have absolutely 100% changed cardiology, cutting-edge things, all of which we do here in Hawaii. And the first one is the aortic valve. So the aortic valve is like the door, almost like a French door. It opens up. It has 3 leaflets, three parts of the door. It opens up one way and it closes shut. It doesn't pooch through the other way. So the aortic valve is the main pumping valve that takes blood from the left side of the heart out the heart and out to the rest of the body. So it's like the last gateway, the last door between the heart and the rest of the body. And it looks usually very thin, like this. You can see it actually, MR, or magnetic resonance imaging, is like magic. It's like opening up the body and seeing it. And this is actually MRI of the heart, which is amazing. And you can see blood going from here, down, falling down, left upstairs room, going down through this doorway to the left downstairs room, which is the main pumping chamber, then out through this aortic valve, the final doorway, out into the body. So you can see kind of blood flowing. And usually the heart valve is very thin and something that you really can't see that well. For some people, the valve gets rusted, thick, hard to open. And if you just look at this valve, it looks pretty thin, it looks pretty flexible, nimble, opening and closing quickly, yeah? And then this one, you can see it's kind of thicker, it's chunkier. It's a different picture, obviously, but the sense of the stiffness of it, the thickness of it, the motion of it, you can kind of get a sense of that, yeah? It just doesn't open that well. And if you kind of imagine that blood is trying to squeeze through that door to the rest of the body, in the normal one, it goes through easy and fine, right? The blood kind of shoots through there in a very smooth, easy kind of way. And when the valve is tight, then it's hard to squeeze through. Not as much blood gets through, and some blood kind of just rams around that door and falls back. So that's aortic stenosis. There are different ways that we can say how bad it is, and so many of you probably have aortic stenosis. In some degree, it just happens as we get older. Doors get a little bit stiffer. I've certainly gotten stiffer as I've gotten older. And things just don't open and close as much. Some people have reasons why that stiffness goes faster. And sometimes it's just bad luck. Sometimes it's family. Sometimes it's other things like smoking and kidney disease and things like that. But we usually kind of put a description on that: normal, mild, small kind, moderate, so-so, severe, bad kind. Yeah, just roughly. It's kind of pajama sizes is kind of how I describe it, right? We can put numbers on it. But usually the description is sufficient. Mild, moderate, severe. Sometimes we stick in moderate to severe if we can't be so sure. We kind of describe it. But just describing is fine. And the way I think of it, and I talk to the young students in the medical school, I describe it like a garden hose, right? And so the garden hose is normal. You turn the water on. The water coming out is very smooth, very clear, very calm. Yeah. And as you put your finger over the end of the garden hose, the water starts to get, it goes faster, for sure. In fact, we can measure that in the heart, how fast it goes. In fact, we use how fast it goes as one way to measure how tight the valve is. Yeah, because the tighter the valve is, the faster blood goes as it squeezes through that pipe. And also, it gets more turbulent, right? The water gets more white with bubbles and kind of splays out, and it's just not as pretty, not as efficient. And it's a little bit more stressful in a way, especially for your finger kind of holding over the garden hose, yeah? And things happen with that. So if you look at the heart, and this is a picture of the heart, and this is what I do, ultrasound of the heart, you can see, let's run this here, that the heart is a pump. So if it's trying to squeeze the blood out of the body, that pump will do one thing first. So if I'm trying to squeeze blood out of a very tight hose, at first, hopefully, my muscles will get big, right? Because I'm working hard, so it's like exercise. And so I'll get strong, and my muscles will get big, and things will be fine. After a while, I'll probably get tired, and sometimes having a really big, thick muscle isn't really efficient. Because then if you think about a bodybuilder, he or she may not be very flexible. And heart has to be flexible too, not just big. So sometimes being big is not a good thing, even if the initial reaction, the initial change is meant to be a good thing. Because on the right side, what happens eventually is the heart gets bigger, floppier, and it's just tired, just not working as well. So that's kind of what happens as the aortic stenosis progresses. So things that people often complain about or have when I see them in a hospital or I'm talking to young doctors across the way about aortic stenosis, there's a concept of SAD. And what that means is people with very severe aortic stenosis either pass out, they have sometimes chest pain or this funny kind of feeling in the chest, or a hard time breathing. And if you can imagine, it's just because blood is not getting out of the heart. And you need blood for the brain, you need blood for the breathing, you need blood just for energy. And so the symptoms you have is purely because blood can't get out of the heart. Nothing fancier than that, to be honest. And the biggest thing sometimes is just I feel tired. I just can't do what I used to do. So how do you fix that? So what's different now than it was maybe about, well, even the last year, things have changed quite a bit. But maybe for the past, certainly the past 8 years or so, things have changed. Initially, super fast, and slowed down a little bit. But we're at a point now where aortic valve surgery or aortic valve replacement has completely changed, completely. And just this year, in fact, there's some big data that was very fascinating and really changed the landscape of medicine and made some of my surgical colleagues a little bit less busy than they were before. You can't use medicine to fix that. If that valve is stuck and it's like a rock, you can't oil it. You can't use medicines to take away that rockness. You got to change it. You got to just change that valve. So what we know is we can go through the skin, right? So we can put a needle through the skin, most often in the leg area, get into the aorta, the main highway that takes blood out, and we can put this catheter, this tube, up into the heart, and we actually can do the aortic valve replacement without surgery. And so it's called TAVR, which is kind of a fancy name, or TAVI, and you've heard different names, but basically it's through the skin replacement. And it's absolutely 100% changed the face of cardiology and cardiac surgery. If you think about it, for open heart surgery, you have to go to the hospital, you have to open up the chest, you have to kind of do your fancy things, put people in breathing machines and close the chest up, and they recover first from the heart surgery, but also from the broken bone, yeah, because you kind of split the chest open. This one, they can go home most often the next day. It's arguable same day, most often the next day. And this is what the device looks like in the bottom. It's really kind of almost like magic in a way, and I still can't believe it when I see it. And many of you, some of you may actually have had it done or had family members or friends that had it done. So that catheter goes across the valve, and then this blue thing is just the way they do it. They put a balloon, and it stretches open the valve, then the balloon kind of collapses, and they pulled it out, and then that valve is kind of stuck against the wall. It's almost like standing against the wall. And if you look at it and look down at it, the valve leaflet is very thin and normal. Usually it's a tissue valve, either most often from the skin of a cow or skin of something like that, pericardium, that they can take off and they can make on top of this metal valve. And it's the whole procedure can take like an hour or so, maybe. Sometimes longer, and then you go home the next day. It's very, very good. Technology is changing, and the biggest change I'd say over this year is that even in patients with severe, is only for patients with severe stenosis, yeah? Because you don't need to fix something that works good enough, right? I mean, you don't want to, there's always risks, there's always dangers to doing things like this. You can still have bleeding and other complications, so you don't want to do it if you don't need it. But we know now, though, that in general, you can do it for almost any kind of aortic stenosis that needs surgery. There are a whole bunch of patients, though, that still need surgery. Yeah, and it's those that have a valve that's really hard to open up. You can imagine if it's a certain kind of valve. People who have the pipe that goes to the heart may not be that open, maybe kind of narrow itself. Maybe the way the valve is placed, the size of the valve, there's not one yet that is the right size. So there are many people who still need surgery, but it's an option that we can consider now for people who before wouldn't be able to get surgery. And even now, people who surgery, in theory, used to be the way to go. This is a nice option for them. So it's really changed cardiology. Surgery still is important. There's still a role for surgery. We still operate and do open heart surgery on patients at all the hospitals in Hawaii. Do open heart surgery because there are people who just need surgery more. But this has really changed the way we think about what we can do inside the heart. Amazing, yeah? And this is the kind of stuff that you probably see. I end up reading like my cell phone news thing more than I do like medical journals nowadays, it seems like. So looking at CNN Health, New York Times, and so on, you probably have seen articles like this saying how Mick Jagger had one actually, right in the middle of his tour actually. I think he canceled one concert and he kind of came back not that long after and was up and doing it again. And that's the reason why there's tens of thousands of heart patients may not need open heart surgery. That's true, but there are many, many, many thousands that still do. And then 30,000 patients. Here are different numbers. And the reason why different numbers, it talks about which group you're in. All is severe, but everyone with severe aortic stenosis aren't the same, yeah? Some are very symptomatic and have a hard time doing anything, and some are fine. Some don't even know they have it. And so the severe aortic stenosis can be different for different people. The other heart valve, the mitral valve, has also changed this past few years. The mitral valve is the valve or the door between the upstairs and downstairs. Yeah, I mentioned that upstairs, downstairs. The aortic valve is here, and this is the mitral valve, so the other valve, other door. And this one really is almost like a French door. It has two leaflets, kind of opens and it closes. Opens and it closes. Blood, in theory, should only go through a door when it opens. Sometimes, just like a window or a door, when a door closes, a window closes, air can still sneak through, yeah? Not everything's airtight. Sometimes the valve has problems and it may not close all the way, but may actually kind of pooch back a little bit. And talk about prolapse or things like that you hear about. So the valve is supposed to close tight. Sometimes it doesn't close as tight as it should. And then when it happens, blood can leak through. In this valve, it can also get tight. It also can get stenotic, but we can save that next time if you invite me back. We'll talk about the leaky kind this time, yeah? So last one was aortic stenosis, tight. That can get leaky too, but we won't talk about that. The mitral valve, we're talking about being leaky. And again, next time, if you invite me back, I'll talk about the tight kind. But the reason why the leaky one is relevant is because it's super common. A lot of people have that. And then also, the best treatment we had for that was surgery also. And now, we can do things non-surgically. So this is the mitral valve, again. This is the main pumping chamber. When the heart squeezes, the blood should be going out this pipe. But here, you see some blood going backwards. And the reason why that's bad is at least two things. One is that the heart has, for every heartbeat, there's some blood going backwards. So the heart has to work extra, yeah? I mean, so it's not as efficient. Eventually, so you think about it, the heart, I'm terrible with math. So you think the heart beats 60 beats a minute, right? And there's 60 minutes an hour, so that's 36, whatever. So a few zeros, right? And there are 24 hours per day, right? So just in one day, for a normal heart rate, me standing here, I just didn't move all day. That's, I think I calculated out, it was like 86,000 or so. So heart beats just in one day. And if I exercise, I got to race after my wife, or if I'm stressed out over something, or if I exercise more than I do, then my heart rate will go up, it's more beats, right? And if every single beat, 25% of blood goes backwards, then that's a lot, yeah? So eventually what happens is the heart starts to poop out. This is kind of working, and you get the heart failure, you get other things, it gets big, and so on. Also, the second thing that happens is that the upstairs room connects to the lungs. And so if there's a lot of blood inside the upstairs room because it's going backwards, then eventually it starts going backwards into the room next to it or before it, which is the lungs. And so you get blood or fluid in the lungs. You have a hard time breathing that way also. So the mitral regurgitation can be bad. Many people have it and are just fine. No problem at all. Because you can have mild, mitral regurgitation, and your heart's pretty resilient. And you could live your whole life with some degree of mitral regurgitation and have no problem at all. But for those who have a lot, the option before was mostly surgery. So amazingly now, there's some technology now where we can also go through the skin. We often go through the other part of the heart, and we have a device called mitral clip. So you kind of goes up there. It can kind of cinch the two leaflets together. So it'll come up, and there's those things like almost like pinchers. It'll kind of pinch the valve, and then you can release it. And if you look down at the valve, it really just brings in the central part of it, and it gives you two small pukas on the side instead of one big puka. And you can put in more than one, so you can kind of cinch in things together. It's not perfect, yeah? It's not like putting in a new valve. The mitral valve, it's bigger, it's harder to get to. So our technology is evolving. So this mitral clip is not that new. I'd say about 8 years or so. There's been one absolutely huge study that came out this year that just shook my cardiology field, showing that if you did this in patients with certain kind of heart problems, it saves lives. And that was very surprising to a lot of people. So for the right kind of person, it can be life-saving. For many people, to be honest, it's not necessary because the heart valve is leaky, but not that bad. And for some people, this kind of thing won't work because there are different kinds of reasons why the heart valve can leak. So we're still learning about that, but to have the technology now and to be able to do mitral valve surgery through the skin is extraordinary. That's why it's great to be a cardiologist. It's so exciting to have new technology and be able to look at the research as it comes out and be able to apply that to patients. It's wonderful to be a cardiologist. Let's move on to the electrical kind. Yeah? So that was more of the valve or structural, the door kind of thing. So let's talk about electricity. The heart, I say, is like a house. Upstairs rooms, downstairs rooms, and then the yellow is electrical wiring in the walls. And the way the heart works is that there's a impulse that comes from this part. It spreads first to the left to this part, and then it goes down this highway or pipe in that way. And it's beautiful. And we have electricians of the heart, electrophysiologists, my colleagues who specialize in working electrical systems. And there are different kinds of things that can happen with electrical wiring, as many of you know. And ironically enough, I do a lot of home repairs. I don't like messing with electricity. That kind of scares me. And cardiologists are kind of similar. The electricians of the heart are a special kind of breed. They do things that I don't quite understand. They start getting a little bit more too micro for me. You know, again, I'm a kind of big picture kind of guy. So luckily, almost all the hospitals in Hawaii have electrician of the heart that specialize in certain kind of things. Atrial fibrillation is when the circuit in the upstairs room is just chaotic. The electrical currents don't really follow that pathway. They just kind of go everywhere. And what happens is that the heart upstairs room then doesn't really squeeze consistently all together. It kind of is almost in spasm because the electrical circuits are kind of going everywhere. And so the heart upstairs kind of quivers. That's what the picture is here. And then once in a while, an electrical current will come down this pathway, and the bottom part of the heart will squeeze. But it's a little bit irregular. It doesn't, because what gets through from top to bottom isn't very consistent, isn't very regular. Sometimes it can go fast, sometimes it goes too slow. But the main thing is that the heart doesn't beat like it should. There are different causes of atrial fibrillation, or AFib for short, or AF, sometimes you'll hear people use. And I won't go through it, but lots of stuff. High blood pressure, the heart valve we talked about, both the aortic and mitral stuff, that can cause blood backing up. Alcohol is actually one of the main reasons. Heart failure. We see a lot in obesity. In fact, there's some interesting data saying that if you actually have patients who are obese with atrial fibrillation and you actually have them lose weight, the AFib burden goes down. This is really fascinating. It's not true for everyone. Obviously, skinny people have AFib too. Some people who are obese who lose weight don't necessarily get better, but it's a fascinating thing that we're still trying to understand why that's true, and other things like that too. And if you have that, your doctor, I know, will go through that with you. And atrial fibrillation in general is something that almost all doctors can take care of. You do not need to see an electrician of the heart necessarily. Sometimes your doctor may refer you to see them because there are reasons why you need an electrician. And there's some things in the house I can fix, yeah? So if the light plate is broken, I can fix that. Light bulb, I can change that. There's some things within electricity kind of stuff that I can do. And atrial fibrillation in general is something like that. So many of your physicians are just fine taking care of that. There are some things, though, that we think about when they see you or see family members with atrial fibrillation. They often kind of will try to think about how it manifests, how does it make you feel. So sometimes the heart can feel like it's racing because that atrial fibrillation the heart rate can go fast. Sometimes you feel like skipped beats because it's not regular. You go like this and it'll stop and then it'll kind of go. People kind of feel that sometimes. You can get hard time breathing, right, because the blood may not come out as fast as it should. You may get lightheaded, dizzy. The main thing, though, is that most people feel fine. They don't feel it, just like high blood pressure. They usually don't even know they're in it. There is a risk of bad stuff, so stroke is a possibility. And the picture on the right is a patient with atrial fibrillation. And you can get a sense that there's a fancy term we use for ultrasound to describe this. The best one, though, is not fancy. We call it smoke. And what this smoke is this blood that's really slow and sluggish. And it becomes kind of slushy almost when blood doesn't move fast, right? If you cut yourself and you bleed, eventually it'll kind of thicken and form blood clot, right? It happens inside the heart, too. And so this is kind of blood kind of thickening and slowing down. If it slows down enough, you'll form a blood clot just like that. And then you can imagine if for some reason something happens, the blood clot, part of it at least, can break off, go down, go out, and cause a stroke, something like that. So stroke with atrial fibrillation is one of the concerns for that. It doesn't happen for most people, but it can happen. And that's one thing that doctors will talk to you about or family members about, kind of the risk of stroke and what to do to decrease that. And this is just mostly kind of to placehold to describe that there are two ways that the doctors will approach that. One is just to kind of control the electrical problems, right? Try to get the heart rate either beating more regularly or beating more slowly. And the second thing is try to decrease the risk of stroke using blood thinners. And I won't go through everything here, but just to give you a sense of when someone has atrial fibrillation, the doctor's thinking about those two things. And again, I didn't put slides in here because I don't understand it totally, but electricians for certain patients can cure atrial fibrillation through the skin now. And so you hear about atrial fibrillation ablation, AFib ablation. I don't do that. You need an electrician to do that. That's what they do. In fact, what keeps the electricians of the heart, my electrophysiology colleagues, is atrial fibrillation ablation. It's so common now. So they can go through the skin, just like the other pictures you had, into the upstairs room now. And instead of using balloons and clips and things like that, they can use either hot coils or super cold coils and burn on the inside of the heart. It sounds kind of weird, yeah, kind of burning the heart. But what it does, it makes a scar, and you can actually force almost electrical currents to go down a pathway, yeah, by using scars as barriers, because electrical currents don't like scars. They can't go through it. The scars are kind of thick and tough. And so electrical current will avoid the scars and kind of go down the path of least resistance, literally, in this case. And so you can kind of create a path down to downstairs heart, and that's kind of what atrial fibrillation is. So this also, for some people, is an option to treat atrial fibrillation. Coronary artery disease, I think this is the last area for the heart problems. That's a pipe problem. So there are plumbers also that are cardiologists, and those plumbers are the ones that fix the pipes. So the angioplasty, interventional cardiologists, they're also the ones that fix the valves also in general, but sometimes people do one versus the other. So I have friends who are electricians and friends who are plumbers. And a plumber, and they're hard to find. Actually, it's hard to find a real plumber, actually, in the cardiologist sometimes. But this is the coronary artery, and this is a picture of the plaque. So when the pipe is free and easy, things are fine, blood flows great. Sometimes, because of diet, because of smoking, because of diabetes, because of bad luck, genes, family history, where it may be, little plaques can start to grow in the wall. If it grows big enough, then it will cause the blood flow to be slower, and the blood has to kind of go around here. So you can imagine that in times of stress, if you're running around, climbing steps, that there may not be enough blood that can squeeze through here if you need it. And people, in that case, will have chest pain or angina, they call it. But if they're resting, taking medications, maybe to kind of help open the vessel up a little bit more, they can be fine, and they can live their whole life with that. No problem at all. We could fix it. We could put balloons in there and stretch it open and things like that. But pretty much people can be fine with here at this point. Sometimes if this plaque pops, and we don't actually know exactly what makes plaques pop. It's like a blister, right? This part is kind of soft, there's kind of stuff inside, and for some reason it pops, then the blood clot can form, it can cause a heart attack or very severe chest pain at rest. And that's the difference between kind of like, and all of this stuff is heart disease, yeah? But you can imagine there's a big range of how patients feel and how present and what we do for them. I'll skip the next slide, it's a little too technical. And then, so let's go to the picture slide. So this is what the plumbers do, my colleagues. And so if you look at the narrowing in the vessel, so the bottom pictures are pictures of the heart vessels, like the pipes that feed the heart itself. Because the heart's a muscle, and just like any muscle, it has to get nourishment to work. And the nourishment comes from these blood vessels, the coronary arteries, that feed the heart itself. And if you block off those vessels, then you won't get, the heart itself won't get nourishment, it won't get enough oxygen, and it'll get strained and may die, that's what a heart attack is. And so you can see it, we can take pictures of it through the skin. This one is older, obviously. We've been able to do this now for 40 years or so, maybe. But for me, even when I started training, this wasn't super duper common. And you can look at the vessels, and you can see right where the arrow is in the bottom right here, you can see that narrowing there, right there, right above and below. So cardiology is great. You can see it. Again, it's very macro. You don't need anything fancy. You can see the narrowing in the pipe there. You can see there's a blockage right there. And you can imagine that if you were a plumber and you were able to put something down there and either kind of ram it out, right, with either a big thing, which we do, like with the snake when the sink gets blocked up, right? Or you can do a balloon, which is the top picture, and put a balloon in there, put a stent, which is a scaffolding, because the heart vessel is kind of rubbery. So if you stretch it open, it may snap back, right? So if you put a stent in there, it'll kind of lock, keep it open, and the balloon will kind of smush the stuff to the side. So that's all plumbers and cardiology do in some ways. They do much fancier stuff. But in general, this is the basis of what they do. They can do fancier stuff on top of that. They can do little whirring blades. They can do kind of fancy stents. But the core of it really is that. In fact, almost everyone who does heart stuff now will get some component of this. We open the vessels up. Kind of cool, yeah? I'm going to go a little bit towards the common and the new things this year. So many of you probably know what the risk factors for heart disease are, and it's listed here: smoking. So don't smoke. Everyone knows that, right? Diabetes. Treat your blood sugar. Everyone knows that. Blood pressure, activity, diet. So let me go over some new things that really struck me even in the past year, maybe 2 years, that changed the way I practice. There's this stuff many of you know. So first is that guidelines, how we treat patients, one size doesn't fit all. We need to be smarter in looking at a patient in front of us and saying, what's best for you? What do you need? And it may be having a blood pressure that isn't by the books, because maybe the blood pressure should be higher in this person. So we know that there's a concept of what people say kind of personalized medicine, and in this building with the cancer people, that means something very specific. But more general concept of personalized medicine, tailoring what you do for the patients, isn't that new, but it's kind of new. And I'll show you in a second what that means. So what we do now is we actually think a little bit more in categories, and cardiologists have always done this, but we're much more specific about what this means and treating based on who the patient is. What I mean by that is patients, if I see a patient in office, I don't have the advantage of these fancy tests to see if they have heart blockages, right? They just come in and sit down. So I have to kind of quickly understand whether they have low risk, moderate risk, or high risk of having heart blockages, or if they already have heart disease. And I need to kind of tailor the treatment for that. And so depending on which bucket you're in, the treatments may vary with that. And so if you're low risk versus high risk, I may treat you very differently, even if you have the same blood pressure. And this is an example of that. It's a pretty picture, but it is mostly meant to show that, particularly in older patients. So my auntie has high blood pressure, and I know for her that if her blood pressure goes too low, she actually doesn't like it. She'll get lightheaded. Even though for someone else, it may be, who's younger, less than 60, it may be better or entirely appropriate. So I know that blood pressure is hard. And the problem is that when the guidelines come out, you look in the newspaper, it'll say blood pressure should be less than 140 or less than 90, yeah. And I feel guilty looking at my auntie saying, yeah, your pressure is 100, whatever, let's leave you there. And people kind of look and say, well, your pressure should be lower. I said, well, no, for her, it's dangerous if it goes too low. So kind of tailoring, personalizing medicine, it has to be first, yeah? I mean, we got to treat the patient. We can't treat the numbers. And because of that, there's some guidelines now on how to treat blood pressures, and mostly just to tell you the state of blood pressure management in medicine is kind of confusing. I don't know how it is for you, but for cardiologists, it's kind of confusing. Because we have one set of guidelines, the American Heart Association, that says one thing, another one from this group JNC, who are a bunch of experts who say a different thing, and you may hear different things. You may hear the guideline says it should be less than 140, you may hear cardiologists say your pressure should be less than 120, and they're both kind of right. The guidelines will say it. The problem is that the guidelines aren't necessarily all together. On top of that, patients are different, yeah? So this is I'm not doing a good job of clarifying things for you. In fact, my goal was to kind of make it harder for you, to understand that one size doesn't fit all, yeah? And then maybe understanding why when you talk to physicians, you may hear different things. One doctor may say, your pressure 150 is too high. Another one say, that's perfect, yeah? And then you may feel that, and the reason why you hear that is because we don't really know, and on top of that, we should be treating the patient anyway, and it's confusing. It's confusing. Trust your doctor, but also know that there's a range of things, and if you do hear other opinions, that's the reason why you may hear different things. Second thing is that a little bit apocryphal in a way, that I almost stopped paying attention to blood pressures in the office. And this is kind of a little bit newer, not too new, but again, how I changed practice and things that you should know. So when a doctor encourages you to get a blood pressure machine and use it, you should do it. You should do it. And if given a choice between an office blood pressure and my patient's home blood pressure, I will always back up the patient's home blood pressure, always. Assuming they do things in a way that I'll show you in a second. Because the office is hardly real life. Yeah, especially if you go to Queens and you got to find parking, POB3, yeah? Yeah, I get stressed trying to get there. And I know where I'm going. So we know that you have to have blood pressure cuff of a certain size. You know, I'm telling you, try to avoid the ones in the wrist. The wrist ones aren't so hot. They're very variable. It's hard to get the arteries in the wrist there. The ones in the arm is much more reliable. Simple kind is fine. There's some Bluetooth ones. There's some ones that kind of can have a bell and whistle. Simple is fine. Cheap is fine. Because if it's as long as it's sold in the pharmacy, CVS, Walmart, Longs, whatever, it has to be tested by the feds, and it has to be good. So you're fine. You don't have to you can get the generic kind, the simple kind at the store. And the important thing I always tell my patients to do is bring it to your doctor's office so you can compare, yeah? Because if it's abnormally high in the doctor's office, it should be kind of high on your machine too. And that kind of gives me some reassurance. And then, and this is more for what I go through with patients when I see them, but also when I talk to my staff is, everything you do wrong will increase your blood pressure a little bit. If you're not sitting down in a hard chair, back off of the chair, 2 feet on the ground, arm at heart level, after you pee, in the morning, the pressure is going to go up. Each of those things will add 1 or 2 millimeters of mercury. So if everything I said, your blood pressure can be falsely high, easily 5, 10 millimeters of mercury, easily, just with those things I didn't mention. Let alone take it twice, average it, or take it 3 times, throw out the highest one, average those. There are different ways to do that are very important. And this picture is pretty good in terms of things that you should be doing when you're taking blood pressure at home, so that when you go see your doctor in office, he or she can say, yeah, I trust your blood pressure. A couple quick things to finish off. Exercise helps a lot. And whether it's low intensity, just walking, high intensity, or strength training, all are good. The more you can do, the better. But what I tell my patients, and I tell myself, is just at least try to walk, with a loved one by yourself for some mental quietness. Half an hour a day around the neighborhood, around the park, around your house. And that's wondrous for your health, mental health, but for your blood pressure. That's a treatment for blood pressure that's almost as good as a pill if you do that. Yeah, it really is. It really is. And this one struck me because it hurts me. So it turns out that you can be very fit, but very sedentary. I happen to be neither fit nor non-sedentary. I'm not fit and I'm sedentary, which is the worst of both worlds. But I have colleagues who exercise, will go jogging every morning, and come in and sit in their butt all day long next to me reading ultrasounds. So we know that sitting is a disease. So hopefully we'll get you up and stretching a little bit. But sedentary, so the number of time you sit down, an average for some people is 22 hours of a day, right? Because if you exercise half an hour maybe, if you're sitting down other 23 and a half hours, that's not healthy. So we know that exercise plus being non-sedentary is better than being sedentary alone. Yeah, so that's the reason why you see some people with the chairs that, the stands, if you see offices, the tables that go up, the thought is they're moving around a little bit more. That's why you see those kind of ball things that people sit on. You can so it's all the same in a sense. And then probably the fittest people are people who are my colleagues at work who retire, and then they garden, or they go play pickleball with their friends, or they go for walks with friends or by themselves. That's super healthy in a way that is complementary to doing exercising, traditional weights or running, something like that. So just being active as opposed to inactive, like I heard here, is great for a lot of things, including blood pressure, including heart disease, and a lot of other things as well. Mental, kidneys, weight, flexibility, joints, so on. So think about those two things, being physically fit, exercising, cardio kind of thing, versus being active or inactive, and then just getting up, moving around, shifting, every few minutes getting up. That's what I'm trying to do at work, is like every 5 minutes, get up, just take a quick move around, sit down, go back at it again, whatever it is for yourself. There's still a lot of science we need to get around that, what that means. And I'll talk about one thing if there's a question about risks, things about how that relates to this thing, all the new devices and stuff like that. So there's me, bottom right, usually looking at an ultrasound, trying to be more left, and also kind of my posture, my wife tells me, so I have a lot to work on. And this is a more of a prescription in a way for activity, and I'll leave it for you to look through. Every day, walk often, be active. Walk to the store, play with your kids. That's what it means, right? It doesn't mean put on, a headband and running shorts and go jogging. It means this, yeah. And it's hard to do that, to be honest. It's hard, but it's important and it's fun. Yeah, I mean, this is good stuff. We should be doing it anyway. And then going up more. It turns out that strengthening muscles, super light weights, is as important as working out your heart. So just 1 pound weights, a can of tomato sauce. Yeah, I mean, it doesn't have to be weights. A book, just kind of moving around like that, does wonders for your heart health, brain health, mobility. Makes you live longer and healthier. And then also activity, yeah? So this is a good picture. Just kind of get a sense of things. And then 10,000 steps a day. I sometimes it's scary how few steps I do. I wonder whether my phone's broken. But and the last slide I'll leave you here, I know we're kind of short on time, is a diet. There's a lot of fancy diets out there. And so the keto diet, there's like all this kind of fancy stuff out there. It turns out the one best diet is the DASH diet. That's what it's called. I'll leave you with this term. You can look it up. There's a local kind version of that, the Dash of Aloha. And a DASH diet is dietary approaches to stop hypertension. But also, if you look at U.S. news reports, this is the best diet to lose weight also. It's the best diet consistently recommended by every organization. This is the healthiest diet. It makes sense. It's sustainable. It has been shown to improve length of life. It's been shown to decrease risk of heart problems. It's been shown to manage blood pressure in ways that things like the keto diet, like a lot of my friends are on, probably a lot of your friends are on, that can lose weight. You can lose weight that way, but it's not necessarily safe. It's clearly not sustainable, looking at my friends kind of yo-yoing up and down. But having said that, there's some neat things about keto and kind of, not so much keto, but kind of low carbs and that kind of stuff we can talk about. But if you're just looking for a diet like I am, I think the DASH diet is really the safest, most scientific, best way to go. And I won't go over details of that because there are lots of books and people who know more about nutrition than I do, and probably many of you do actually. I don't claim to be a nutritionist. I may have missed that course in med school perhaps, but either that or I'm sure they teach more of it now than when I was there. Diet is key, and it wasn't so appreciated in the past. There's a Mediterranean diet, there's like the fasting diets and things like that are out there. It all have pros and cons, but a DASH diet is kind of what's recommended, and I think the most data. That's a picture of what it looks like. Oh, last thing. Okay, one more thing. Aspirin. That's changed. I kind of put in things here that changed. Used to be aspirin a day keeps me away, yeah? And then low dose baby aspirin is a good thing. What the recommendation is now, surprisingly, what I learned in medical school was wrong. That an aspirin in patients who are generally pretty healthy to prevent a first heart attack is not necessarily the right thing to do. You got to talk to your doctor because there may be reasons to do it, other things, but to prevent heart attacks in general, if you're taking an aspirin and haven't talked to your doctor about it to prevent your first heart attack, that's changed in the past year and a half even. I was taking aspirin. I stopped. Yeah. And my dad, I think he doesn't listen to me, so he probably still is, but I'm encouraging him to stop. And we know the reason why is because it causes bleeding. That's the way it works. And always doesn't prevent heart attack. So that's a change. Talk to your doctor, though. Just don't make any changes by yourself. But if you're taking aspirin for that first heart attack, just say, hey, I learned in medical school, maybe not for me. Thank you.